we should be all set to go
Mm-hmm.
with our welcome stream. Great. So some of our objectives for today to help us get started is we're going to really talk about how what's been happening the last decade or so is a shift, a change in our treatment models, really based on all this new information that we have around the neuroscience and research of how to better treat substance use disorders, and really shifting to away from an acute approach to a chronic health condition. We're going to talk about really in three different ways of implementing evidence-based short-term interventions, but we're going to talk about it from skills that we can use with our clients. We're also going to talk about skills that we can use to change our professional selves, and then also in the organizations or even in the systems that we work. Are those three areas adapting to what we now know around substance use disorders? So we're going to weave that in, and then we're going to focus in on specific skills, around cognitive behavioral therapy, CBT, acceptance and commitment therapy, ACT, and mindfulness. We're going to talk about specific tools to really help our clients identify and for them to develop skills to help them control behaviors that are associated with cravings and triggers with substance use. So we're shifting, we're changing and moving away from some of the old ways of treating addiction and really creating a new system and a new approach to how we treat people with substance use disorders. And so some of that shift is really moving away from some of the old concepts that we have that we still see. And the treatment, I saw a question come up, and so just to remind the audience, as folks are probably joining in a little bit late, as everyone gets settled in, that we are going to make the slide deck available, and there will also be a recording that will be posted on the IRETA website, so that will be made available to everybody. So just so everybody knows that. But we're making a shift where the idea that getting treatment to folks is better than no treatment. And even moving away from old concepts of detox, where we know that detoxing a patient, just removing the substances from them, around them, in them, is not effective. That's not effective treatment. And how rapid admission, making sure our patients, when our clients are ready to get treatment, when they want that treatment, that we know that rapid admission, what are we doing to improve treatment engagement? And then really shifting from away into looking at addiction treatment as a harm reduction approach, that no single approach is most successful for all people. We used to come from an approach where we felt that an abstinence-only model was most appropriate for all people, and that if folks were using substances at different degrees, that meant they shouldn't get treatment until they're ready to stop using all substances. And we've shifted that, and we've shifted into more of an individualized approach to care, where that duration in treatment, or even the intensity of treatment, the length of care, is really individualized to the individual person. So the idea that if, I remember 10, 20 years ago, if someone failed at outpatient, we right away sent them to residential treatment. And even when I use and talk about the old times, you can hear some of the stigmatizing language that comes from me, right? Where I blame the patient for failing and not looking at the system, or not looking at the level of care, or the role that we play in providing an opportunity for success for those patients. And even, what does failure mean? What does failure mean? Does that mean reducing use as a failure? And now we look at that as, no, that's a success. So we're really shifting in treating substance use disorders across a continuum of care, where we understand that addiction is a chronic health condition, and that we don't want to just throw a bunch of resources like a rehab stay at someone for 21 days, which costs a lot of money and is high intensity and takes them away from their community and their family. That maybe it's better to spread those resources out along the continuum of care over time, when folks need those resources and not using them when they don't need those resources. So really shifting how we think about providing care and focusing that care on counseling, behavior therapies, also medications. One of the opportunities that we've had, the lemonade that's come from the lemon of the opioid epidemic, is the focus and awareness of the importance of using medications to treat opiate use disorder, but also other addictions like alcohol use or nicotine and tobacco use disorders. And really focusing in on strengths-based approaches and addressing multiple co-occurring disorders now, that we don't really need to wait, that we can treat mental health conditions, behavioral health conditions, and substance use disorder conditions at the same time. So why don't we do it? What are we up against? Well, there's some important things that I think we have to take into account, and a lot of that has to do with the stigmatizing and the discriminatory approaches that we've had and treated people with substance use disorders over time. And so this is a great resource. It's Change the Narrative. The website is on the slide deck here, that really talks to a lot of the mythologies or the myths or the stigmatizing language of really stuff that doesn't belong. And when we talk about substance use disorders, as we see words like addict, or when we talk about medication-assisted treatment, treating one addiction for another, really changing that narrative around what addiction is, what substance use disorders are, and maybe more importantly, what they are not. So part of this approach, this shift that we're making in utilizing these evidence-based skills, these evidence-based tools, really calls on us to start to think about and challenge some of the beliefs that we have about people with substance use disorders and the perceptions that we have around people with substance use disorders. And so it's important that we talk about these issues because they are one of the main reasons why people who have substance use disorders are not able to access care. We know in this country that somewhere between 10 to 20% of the people who need care, who need treatment for a substance use disorder, get it. That is astonishing to me. Can you imagine we said that about any other chronic health condition? Can you imagine we said that about diabetes, where people who have diabetes, 80% of the people who have it don't get insulin, don't get the medication and the care that they need. Or for cancer treatment, that only 20% of the people who have cancer get chemotherapy. There'd be outrage. And yet this is what we're up against when it comes to the treatment of substance use disorders. And what we're talking about specifically is bias, stigma, and discrimination. And so we're talking about, when we talk about stigma, it's important for us to understand these definitions and differences, is that when we talk about stigma, we're talking about the ideas, the concepts, the negative stereotypes, the things that we think in our heads, the beliefs. When those beliefs take shape in our behaviors and change how we treat people with substance use disorders, that's when stigma becomes discrimination. It's that we change and treat people differently. So I'll invite you today, as I talk about substance use disorders and use the word addiction or substance use disorders, to change that out. Think of a chronic health condition like diabetes or hypertension. Would you think the same way? Would you react the same way? Would you treat the same way? And that's a great way to start to think about our own internal potential biases, our own intentional ways that we stigmatize people with substance use disorders. The other reason we need to talk about this today is because it's also about educating our patients. It's talking and validating what many of our patients have experienced before they've met you, before they've made it to the center of care of which you are, of how they've been treated over time. And then also helping support our teammates on our team that we work with around this. And so when we talk about bias and discrimination, there's two seats of it. There's two main factors: cause and controllability. This is the seat of where this comes from. And when we talk about cause, it's the extent that people believe a person is not responsible for the attribute, behavior, condition when they don't have that, when we say it's not your fault, that stigma is diminished. It's not removed, it's not gone, but we know it diminishes in its intensity. So when we talk about people with substance use disorders, we don't typically hear things like it's not their fault. We're going to talk a little bit about the challenge to that. And then controllability, the extent that people believe that that attribute, that behavior condition, that it's beyond the individual person's control. They can't help it. Again, when we talk about substance use disorders, they can't help it. How often do we hear that in conversations about people with a chronic health condition, like a substance use disorder? So, as with other chronic medical conditions, we know that people who develop a substance use disorder, between 40 to 60% of them, it's genetic. There's nothing that they could do to change their genetic inheritance around whether they have a substance use disorder. Other influential factors are the environment, the neighborhood that they grew up in, the social factors. All these things are shaping a person's vulnerability to addiction. So it's important to think about cause. Is that associated with cause, and is it associated with the person's ability to control? So these factors, they determine that person's propensity, not just to start using, but also to keep using them. And really determines their susceptibility to the neurobiological changes that occur in the brain that characterize the progression of addiction. So we now know, because of the changes in the science that we're starting to talk about, that substance use disorders are not a moral or spiritual failing. They're not a lack of will or responsibility. They're not a character defect. There's no such thing as an addictive personality type. That's not in the DSM-5. And people with substance use disorders don't have personality components. And this was tough for me, because this was a lot of how I was trained, that people with substance use disorders don't have personality components such as denial, rationalization, defensiveness, manipulation, resistance. They don't have any other abnormally robust defense mechanisms than other people with chronic health conditions. And so we've developed a stigma around how we treat people with substance use disorders that's really stuck for generations. A lot of these things that have no evidence base were how I was taught to treat people with substance use disorders. I was taught to really focus on helping patients take what we called a moral inventory, and really confronting them and talking to them about their responsibilities and teaching them how they need to rebuild that level of responsibility, and then listing and talking about their character defects. We now know that there was no evidence base behind that, although these components may be a critical part of a person's individual recovery plan. We now know that many of the approaches was doing the very thing that we talked about in the beginning of the webinar, was interfering with the most important component of care, my relationship with patients, and was causing a separation and a divide when what we needed was a unification and a relationship of support and teamwork. So we now know from the science of what's come out from the Surgeon General's report, DSM-5 has removed dependence and abuse. We've changed that to a spectrum disorder of mild, moderate, severe. And also some of the advances from Dr. Volkoff, Dr. Koob, McClellan about the neurobiological advances of the brain, that what we're talking about is a brain issue and a chronic health condition. So this is going to bring us into understanding quickly a little bit about the neurobiology to help us make sense of things like cognitive behavioral therapy, or why mindfulness works, or acceptance and commitment therapy. And so when we think about addiction, a lot of times we get stuck. I'm going to try and use my marker here because okay. So I think I have my marker. No, I don't. I practiced. Aha, I got it. Okay. So what we have here is from that article a picture of your brain. This is actually your brain on drugs. And in these boxes are the DSM criteria that we see here. I put these in here. They're not in the original article, but I added those in. And typically what we get stuck focused on is thinking about, we talk about addiction, the intoxication, the get high phase. And we miss out on the opportunity to treat two other major components of addiction, of when our patients experience withdrawal and negative affect, which is over in this area, and then preoccupation and anticipation. This is the craving area, which we know is so critical to show us how far behind we are. This stuff was not even in DSM-4. DSM-5 came out, and I think it was 2013, and finally added in what we knew for a long time in the field, so important, was cravings and urges to use. And so we get stuck a lot of times on one very small component of addiction. And you hear it all the time in the news, the media, about getting high, about feeling euphoric, about people who don't care about anything else, but they just want to feel good. When in fact, we know that working in addiction, because of the neuroadaptions that happen in the brain, the shifts in drivers that result from those neuroadaptions, that hijack that part of the brain, that what starts out feeling good for someone with a substance use disorder had long passed. And actually, people who have a substance use disorder need to use that substance to just not feel awful. They need to use that substance in the second part, just not to feel depressed, anxious, or restless. And that preoccupation has now shifted into obsessing and planning from just kind of using that drug when I wanted to or not. And we see the behavioral changes that occur. So we know from the neuroscience that many of the behaviors that are associated and sometimes stigmatized against due to a person's, what we falsely attributed to their personality or their makeup as a person, actually are exactly what's going on in the brain. So we now, I have to clear my screen. So we now know from our ASAM definition of addiction is that addiction is a chronic disease of brain reward and motivation. So we're going to talk about why our skills are going to work so well with this, that it's pathologically pursuing reward or relief, and that it's the inability to consistently abstain, which means returning to use is part of the definition of addiction. And it's impairment in behaviors around control, craving, and an inability to recognize significant problems with the person's behavior and their interpersonal relationships. And there's a dysfunction in emotional response. So people with substance use disorders are behaving, doing, thinking in ways that are exactly according to what we know goes on according to the neuroscience. So we have an opportunity now to shift how we treat people with substance use disorders and understand that addiction is like other diseases. It's preventable, it's treatable, it changes biology in the brain, and if untreated, it can last a lifetime. Okay, so as we move into our tools, we talked about relationship as such an important component. And as I talk, we're bringing in our motivational interviewing skills, and we're bringing in the 4 key principles of motivational interviewing of partnership, acceptance, compassion, and evocation. And I love the concept of evocation because it really comes and speaks to us from a strengths-based approach of understanding that we don't come from a deficit approach with our patients where we have to fill them up with information, learnings, things. What we understand is that in our cup, this is a cup, I know it's hard to believe, are the resources in here that the patient and client already has. Our work is to elicit this, to pull it out, to draw it out. And when we think about bringing in new skills for people with substance use disorders, we have to think about the fact that we're removing one. People with a substance use disorder, are using typically have very good reasons to be doing so. So asking the question, what is this doing for you from a motivational interviewing spirit? Why are you using? Not judgmentally, but inquisitively. And starting to explore other areas like trauma. Are there comorbidities like depression or bipolar disorder? What are the social dynamics? Does substance use help me manage my relationships? What's going on in my environment? So as we think about adding in tools to help keep our patients afloat, to help them manage, we also have to think about we are taking away a skill that they have adapted with tremendously negative consequences to help them manage. How are we going to replace some of those things to help support them? The other thing to keep in mind are the cognitive effects of substance use disorders. We talked a little bit about this, about what happens in the brain. We know that over repeated use, that impacts and hijacks the drivers in our brain around episodic memory. So our ability to remember things like times, places, it's associated with emotions, other contextual information of kind of the who, what, where, when, and why of my knowledge base has been impacted. And we also know what's impacted is emotional processing, ability to experience and process emotional experiences has been compromised, hijacked by the brain, hijacked by drug use in the brain, and also executive functioning, my ability to plan, my ability to make decisions. So addiction is a chronic disease that involves compulsive or uncontrolled use of one or more substances in the face of negative consequences. What that means is that I continue and am compelled to continue to do things that I don't want to do. So do our interventions, do our approaches, our plans, our expectations, do they line up with what we know? Are we asking our patients to do things that they realistically can do? And that's an important part of our question. And so some of the tools that we can start to use to truly impact substance use disorders and treat addiction, it comes from the combination of using cognitive behavioral therapy, mindfulness, and acceptance and commitment therapy. And I love to talk about all three of these at the same time. And again, we're being informed as we talk about these things of cultivating our relationship from the spirit of motivational interviewing and utilizing these three skill sets. So let's dive in and talk a little bit about some of the skills. So cognitive behavioral therapy really is what we talk about when we talk about relapse prevention. And I use the word relapse prevention because I think that's typically the word that we use, but really a more strengths-based approach is really talking about moving from relapse, which sounds like a negative thing, to a return to use. But in CBT, what we're doing is we're teaching, we're encouraging and supporting our patients about how to reduce and or stop their use. And we're building skills to help them gain initial abstinence and move into recovery. So really it's the skills to sustain recovery. And when we talk about relapse prevention, it's a CBT treatment that focuses on that maintenance stage, the maintenance stage of recovery, helping our patients prevent the occurrence of a return to use. And if they do return to use, what it's doing, it's preventing the severity and the intensity of that return to use. So when we talk about cognitive behavioral therapy, we're talking about, many of us are familiar with, and I know we had a great, Irita had a great presentation last month, specifically on cognitive behavioral therapy. But what we're talking about is the identification and the interplay of behaviors, of situations, emotions, and thoughts, and the way that these components seemingly work together at the same time and interact and interplay with each other. And we're going to talk about how to break these components down to help our patients become more aware of what's going on. And so when we talk about behaviors, typically we're talking about substance use, or we're talking about behaviors as alternatives to use when we talk specifically about substance use disorders. And when we talk about situations, typically what we're talking about in the situation component are triggers and cravings associated with use. And then the emotions and the thoughts are the emotions and thoughts that are associated with use. So when I think and have a thought, am I thinking about using a substance, or am I thinking about some of those alternative behaviors that I have and how to help our patients come up with a plan to utilize those? So we're using that old ABC model from Albert Ellis of looking at the activating event, a behavior that occurs from that activating event, the cognition, the way we think about that event, and then what we do, what the results of that were, and then the opportunities that we have to dispute or interrupt that part of the process. And then bringing in the concept of mindfulness. And mindfulness is such a wonderful match with cognitive behavioral therapy because it really gives us a new approach to the skill set around the cognitive component, the thinking component of CBT. So when we talk about mindfulness, it establishes for our patients and for ourselves a sense of self that's greater than our thoughts. So think about, ironically, that for a minute. That establishing a sense of self that is greater than our thoughts. What that does is it interrupts and creates a space that helps us peel back and pull back from our thinking. It also works in our emotional experiences, the way that we feel. Mindfulness establishes a space, a way to intervene, so that we are not so quick to react around thoughts. And the way that we do this is that we can develop the observer self. It helps us examine thoughts, to separate from those thoughts, to realize that we have the ability to see our thoughts, our feelings, also to search and scan in our body, to understand and identify emotional experiences, to look into our memories. And what that observer self does is gives our patients a greater sense of awareness. It starts to slow things down. Where thoughts are seemingly automatic, it starts to slow that process down to realize that we can interrupt the thought at any time. And mindfulness, this observer self, becomes a catalyst to recognizing those seemingly automatic thoughts, those emotions, and those behaviors that are so important to identify in cognitive behavioral therapy. So what mindfulness is doing is we talked a little bit earlier about the brain, how the impact of drugs and alcohol in the brain shift those drivers, those neuroadaptions. Mindfulness literally is helping to rewire those pathways, those disrupted neural pathways that have been hijacked, that have been shifted, that have been changed, can be changed through mindfulness. And we can do this in vivo, meaning that we can do it right there with our client in the here and now. And one of the ways to do that is to really use the breath. That breathing can be a pathway to mindfulness. So I'm just going to pause for a second here and invite you to join me, and I'll do it with you all. It is for us right now to just kind of focus and become aware of our breath. In fact, now that I'm aware of my breath, I realized I wasn't breathing so much because I got excited and I'm presenting and talking. And so now that I'm aware of my breath, I'm going to close my eyes and shift my mind's eye to my breath and allow myself to breathe in for 3 seconds. And then to exhale for 3 seconds. And I felt so good, I'm going to do it again. In for 3 seconds, and then out for 3 seconds. And then breathing in for 3 seconds, and then out for 3 seconds. And so just shifting and helping our clients break away from whatever's happening in the session with us, or taking a break even before we start a session, or like right now, you can maybe even hear my voice is a little bit more calm and a little bit more slow and maybe a little bit more aware. That using diaphragmatic breathing, of focusing on the breath and breathing in and breathing out, gives me a sense of control. It slows down my cognitive processing and thinking, because if I'm focusing on my breath, I actually close my eyes and separated from all of you in the audience for a little bit, and now have returned back in a calmer way. It really is a pathway to mindfulness that can be so effective to help support our patients in breaking away from strong emotional experiences or fast-paced thinking thought processes. The other pathway that we can use is room awareness, of helping our patients focus in on the room and what's going on around them. So looking around the room that you're in, noticing colors and pictures, the corners of the wall, the structure. These things help ground me, focusing on things like colors, or using my body, a body scan, of scanning my body of what I'm feeling or what I'm not feeling. So this process, this mindfulness process, builds the muscle of awareness that we need in cognitive behavioral therapy, that I become aware of my body, and I become aware of my body and the energy that's held into it, that I'm aware of my thoughts, that it breaks into that over-identification with the mind, and really starts to give me a sense of control, that I have control, I have power, and I can manifest change by the way that I think. I can impact the way I have an emotional experience. So these new tools, I'm starting to let go of trying to control things, and I'm more shifting into an embracing and a sense of empowerment. And that really aligns in a lot of ways, if folks are familiar with connecting to the serenity prayer, controlling what I can control, letting go of what I can't, and the wisdom to know the difference. So bringing those together. So bringing in mindfulness is also a wonderful match with some of the core principles of ACT, or acceptance and commitment therapy. And so these components really match nicely with mindfulness and CBT. And so the first component is cognitive diffusion, where we learn to detach from our inner experience by interacting or relating to them differently. So some of the techniques that we talked about are great to help our patients with cognitive diffusion, of detaching from that inner experience. This comes up so strongly for patients with substance use disorders when they are in the experience of craving. Also acceptance, where we allow thoughts and feelings to arise without trying to change their form or their frequency. Again, instead of fighting the thoughts, fighting the thinking, we embrace it and allow it to come out. And in our relationship with our clients, we can create a safe place for them to explore thoughts, to explore maybe feelings that were previously unacceptable, or they thought inappropriate or troublesome or scary to experience. And then the third tenet principle of ACT is mindfulness, that we talked about, which really helps us retain contact with that present moment, of continually bringing us back to the present moment. And in number 4, self-understanding is letting go of concrete and inflexible thoughts or ideas about how I think about myself, and really moving to an understanding of oneself within the context of situations. So bringing in that idea and concept of compassion and care and self-love. We talked about how many of our patients, due to the bias, the stigma, the discrimination that they've experienced because of having a substance use disorder, have gone through, that they've internalized much of that. And so bringing that sense of self-understanding as we help them dispute some of that negative thinking in CBT can be so valuable. And then looking at values, of learning what's most important to oneself. And this really helps inform our approach with motivational interviewing, that we understand that for many of our patients, it's not about motivation. Many of our patients don't want to use. They're compelled to be doing something they don't want to do. And they don't want to use because they want to get back to their families or their jobs. Really learning what's most important, what our patients value the most, help set up individualized treatment plans, help set up the focus of care that's most important to them. Connecting to their values is going to help elicit what it is that motivates them to get to you, to work with you, to be with you, to do what it is that they want to do to enter into recovery. And then making that commitment, committing to an action, that efforts to empower behavioral change and moving to an understanding of oneself within this context, that we start to think about setting up goals and making change through these principles of acceptance and commitment therapy. So these three approaches, these three evidence-based practices are going to inform what we're going to set up now as our tools for the toolbox. We're going to talk about the 5 W's, quality questions, how to deal with triggers and activators, giving our patients the psycho-ed they need, and then really blending in red flag thinking. So we talked about our triggers and our activators, and we know for our patients when we work on relapse prevention planning, it's really bringing into awareness and consciousness the idea of how I just ended up there, of focusing in on how patients' triggers can be shared, that people have similar triggers and activators, but they can also be very personal, and that we have to connect with what our internal triggers are and what our external triggers are. So starting to get at some of that are the 5 W's of really helping us understand our activating events and our triggers. So the who comes down to a lot of people. Who are the people that I associate with using? And what? Again, back to what does this do for me? What is it that my drug and alcohol use does for me that I struggle to do when I don't have my drug, when I don't have alcohol? And when? Is there a time pattern? Are there certain times of the day, work week, places that times that I think about using? And then where do I use? In those places. So the people, places, and things, the places where I use, and then why? What am I experiencing? What am I feeling? What is it, again, similar to the what, of returning to use? That we understand that returning to use is happening before a person actually returns to use. So these help the patient, listing these, putting these out, identifying them, help bring into awareness, cognitive awareness when I am in a danger zone. The who's, the what's, the when, the where's, and the why's. Listing these out, talking to our patients, helping them become aware, bringing this into their consciousness is so important because we know it's been shifted. Our patients, because of the neuroadaptions, don't necessarily recognize the triggers. We hear this all the time, right? The person knew they had a drug test. They had to go to their PO, or for their job, they knew they had a drug test and they tested positive. How could they do that? Well, that's because they have a substance use disorder. That's because the changes that have occurred in the brain over time, the neuroadaptions, they have lost voluntary control. We need to rebuild that model back for our patients so they can become aware of how they can start to get a handle on these indicators that help me recognize my thinking, my patterns of behavior, my thoughts, my emotions, all the things that lead to the choices that I make and how I behave. So we can get at this stuff by asking our quality questions. And you can make a checklist. You can use things like alerts and reminders in your patient's phone. Most of our patients have these. Is really talking to our patients about what was going on before you used. What was happening to you? What were you experiencing? Were you in a fight? Were you in an argument? Were you feeling lonely? Really getting into what was going on before you used. And where were you? Where were you when you began to think about using? What was going on? Were there environmental triggers? Were you on a street corner, a park, a place? And what was the emotional experience? How were you feeling before you used? And where did you obtain and use drugs, right? Really listing and putting those as places to know that, hey, if I end up in this place, I know there's a pretty high percentage that I'm going to end up around drugs or alcohol. So making this a trigger before it becomes a trigger to use can be so helpful for our patients. And then connecting that to the people they use drugs with, and then also connecting to the consequences of what happened after they used. So breaking these components of these triggers down, helping identify these triggers and activators, helps our patients move from what is seemingly automatic and living in a world where things are happening to us to an opportunity where patients are empowered, where they are in control. So we're looking at our internal and external behaviors, our cognitions, our emotions, and our cravings. And if we look at this, we have an opportunity to get off of the train ride here that is a return to use. So this is the typical pattern of what happens along the course of a relapse event. And we know that oftentimes we have a trigger. And there's an opportunity for us to derail and think about what behaviors can I engage in to impact that trigger. What thoughts now can I use to impact the way I'm thinking to get off that train ride to return to use? And then cravings come next. What emotional experiences am I experiencing? Can I become aware of? Again, and then even if I return to use or am in a place where I am going to use, what are the ways, what are my life jackets that I can use? What are the tools that I can use to impact? So anywhere along this continuum. So one of the first things we're going to talk about are the behaviors associated with use. So I have to erase my stuff there. So behaviors associated with use. So really looking at behavioral activation planning. So planning with our patients non-use behaviors, starting to create a structure where they start to avoid the people, places, and things. Are they looking at things like, am I eating a nutritious meal? Am I getting the sleep I need? Am I following the structure that we set up? Am I missing appointments? These are all the warning signs that we want to look at. And then assigning our patients homework of coming up with a planned schedule, putting structure back in our life. When we put structure in our life, it takes our thinking out of it, and we follow the structure and helps repair those pathways again. When we recognize awareness of activities like those people, places, and things, again, bringing that awareness in. And skills for stress management. Patients many times struggle with things like anger management. Behavioral activation planning is so helpful in this, in coming up with ways to handle stress in more pro-social, positive ways, and then making that list, listing those high-risk situations, listing low-risk situations, helping our patients come up with that structure to change and choose alternate behaviors. Some of the red flag behaviors that we want to look at are when our patients start to experience cracks in the structure, when they start to skip things or not do things like missed appointments, missed obligations. Those are our warning signs for our patients to become aware that they are potentially moving along that continuum of a return to use. Are they taking care of their bodies? Are they eating healthy meals, nutrition? Are they exercising, getting the exercise that they need? The sleep and rest. Are they showing up for work? Are they engaging in other risky behaviors that normally they wouldn't do, like sexual promiscuity or gambling, things of that sort? So helping our patients become accepting of these things, bringing them out of the light, externalizing them, becoming aware of them. One of the techniques that we can use is reflection, of mirroring back to our patients so that they can see what it is that we are seeing and hearing, using our patients' discrepancies where they say things like, I really don't want to use because of my children, but I'm really having a lot of thoughts of wanting to go use, and I think I'm going to go hang out with some of my friends who I haven't been around. Bringing that discrepancy in, saying, gosh, does going to hang out with the guys that you used to get high with, does that connect with your goal of being more present in the life of your children right now? And then disputing. Sometimes we have to act like a coach, of disputing like a coach and disputing some of that talk for our patients to model for them how to do it. And then the second part are the cognitive components of of recognizing thoughts associated with use, and disputing those thoughts, thought stopping, where we see our patients, a lot of the traps, they reduce their options, where they say things like this won't help or that won't help, and starting to help them develop a way to dispute that. Or when we hear patients or clients talk about saying things like, gosh, I totally got this, I'm never going to use again, that globalization, or as a way, which can be a real important warning sign for us to take care of. And also some of the negative things, like I blew it, I used, and so I might as well just give up and go back to using all the time. Again, disputing those negative thoughts, starting to replace those thoughts with pro-social positive options. We hear our patients say things like, I have no power, I have no control. Well, is that exactly true? You were able to get here today. And so helping our patients bring in that level of dispute can be so helpful around challenging that negative self-talk. And then around psychoeducation, that really helping our patients understand that addiction is not a moral failing and that it's a chronic health condition. And that when patients, if they do return to use, that we really shouldn't be surprised about that. We don't want them to return to use, but it's part of the definition and it's part of what we know to expect according to the neurobiological behavior changes that occur in the brain. So these are opportunities to grow your recovery capital, to go back and look at that relapse event and say, okay, well, where did we miss and what were the opportunities for proactively impacting and approaching where we could have jumped off that train ride to a return to use. So really bringing in that ACT approach of self-understanding, of letting go of those concrete and flexible thoughts or ideas about oneself and moving to an understanding of oneself within the context of situations. So bringing that into the session, talking about it, connecting with your patients so that it's okay for them to talk about these things so that we can make some changes. Some of the red flag thinkings that we talked about are absolutistic, when we hear our patients go speaking in extremes, when we hear black and white thinking, when they start to discount the positives or they start to jump to conclusions, fortune telling or self-blame. Again, using our red flag interventions of asking a patient permission. Is it okay if I bring some of what I'm hearing up to you so that you can hear this back, reflecting it back, asking them permission, can we talk about this? Using those discrepancies and then disputing like a coach. And then recognizing the emotions associated with use. This is important for us to really differentiate that sometimes we talk about negative emotions and positive emotions. And really what we're talking about is not bad emotions or good emotions, but negative emotions, and typically they make us feel not great. Positive emotions, more on the positive continuum. Helping our patients understand that their emotional experience is not always proof of the truth. That just because we feel a certain way, just because we have an emotional experience, it may mean that your thinking is right or correct. It may mean it's a validation. It may mean that, but it may not mean that. And so really, we want to make sure that our patients understand that what they feel and what they experience are very real and they're very present, but they may not mean the truth. And that's where it's so helpful to bring in some of those CBT tools around thinking about how our thoughts generate those negative emotions, and also bringing in ACT acceptance and mindfulness of allowing our patients to experience their emotions, whether they're positive or negative, because it's not the emotions that disrupt our patients, it's their restriction of those emotions, the things that they do not to experience their emotions, which cause them problems. And typically, drugs and alcohol work really well to not have an emotional experience or to get you out of it or to relieve yourself from tension and stress of an uncomfortable emotional experience. So with our patients in relationship, creating a space that's safe for them to start to wade into and walk into the emotional experiences that they may not have been very comfortable or grew up in homes where it was an unacceptable experience, to experience with you starts to break the dependency on needing something outside of themselves to help them manage their emotional experiences. So recognizing these emotions and then finding ways to externalize them, whether it's with us, with a sober support person. Even there's research that shows that even patients who imagine talking to a positive person is almost as good as having that conversation with that person, is if they start to do that process work with that person in their mind. And so bringing those tools in to have those safe emotional experiences can be so valuable for our patients as we help them manage that emotional component of relapse prevention. So red flags, when our patients experience strong emotions, helping them understand, hey, is something going on here where do my emotions right now, do they match the situation? Are they too strong? If they are too strong, does that mean that maybe there's something going on inside of me that I have not attended to? And is this emotional experience a trigger for me to use? So again, creating that safe space for them to help them identify so that they can talk about and experience these things in a ways where they become more aware. So some great tools for managing emotions, going to the breath. It helps slow things down, and we know, just like we did 3 breaths together, if we allow ourselves to have those 3 breaths, typically that the highest level of intensity of emotion drops, that it passes through us. And then finding ways to externalize, that if we can externalize our emotional experience and support people, if we can do things like get physical, like exercise, doing something like a cold shower really works. Getting into cold water helps reset, especially for people with trauma history, to reset the brain, to calm the system down, to get out of that fight or flight response. And so helping our patients not to act out on their emotions, to not just do something. I have the bullet point, don't just do something, stand there. To actually be in that emotional experience where they can start to ride that wave of emotion. Teaching our patients to trust and use their body. The body knows better. That helping them do body scans helps them identify and experience where they may be holding emotional energy. My brain may be saying, Nick, don't get upset about that. We're not going to let that person make us angry. Meanwhile, my stomach is flipping and my heart is pounding. Well, no matter what I tell myself intellectually, cognitively, my body is experiencing anger. So if I don't bring that into alignment, I can't use my brain here to use the skill sets that I know to help me manage my anger. So the body and where I hold that energy can be such a helpful way for me to really become more emotionally congruent, to pull my mind in alignment with my emotional body. So using mindfulness, the eye of awareness of a body scan, putting myself in a room scan to help ground myself, and then looking at those body signs. Like, am I sped up? Do I have a stomach ache? Do I have increased energy? Do I have a twinkle in my eye? Some of our patients even may act as if they are on a drug or alcohol, or act in a way where that muscle memory of what the drug is like to have in their system. And then finally, 4, if we do get to that craving, before all these cognitive, emotional interventions that we have, we do sometimes get to that craving. So it's a shift from resisting and fighting to really moving into manage, of riding the wave, of really having a preparation in place. So I have a plan to know what to do, a structure, plan it out. This helps my brain. It reduces my overwhelmed brain of negative options and gives me an idea to say, okay, I know what to do. I'm going to plug into this. This is what I'm going to do if I'm experiencing cravings. So behavioral activation, non-drug related activities. What is it that I can go do when I'm experiencing these cravings? Also helping build refusal skills for our patients. If I do end up in a place, a triggering place where there's drugs and alcohol around me, how do I build the assertiveness skills to practice saying No, thank you. I don't want any of that. I don't use drugs. That's not for me. Role-playing that, practicing that, a lot of times typically with our patients, that can be really challenging because it's with their own family. Role-playing that can be such a great way to help support them. Helping our patients take times out, thought stopping like we talked a little bit about, and then helping our patients measure their cravings. Helping them, giving them homework when they go home to talk as a way for them to bring back to you, my cravings on a scale of 1 to 5, I was at a 2, I was at a 3, I was at a 4, really helps create a language so that you can measure change, progress, and how well certain interventions work around different levels of cravings. So really what we're talking about is partnering with our cravings. Is bringing and feeling comfortable to bring those into our sessions. Have our patients think about a time when you were craving. Think about a time when you wanted to use drugs or alcohol. What were the body sensations? Make a list of it. What were the emotional experiences? What was I thinking? Making a list, writing these things down, doing this in a safe place with you, in the session with you, helps them prepare for when they leave the session. And so a great tool to do this, there's millions of different versions of this tool out there, our relapse prevention awareness tool. And again, it's not just about using, it's about helping address the people, places, and things that activate our patients, that bring us to those cravings, is making a list of really looking at that activating event of the people, places, and things, those 5 W's that we talked about, the who, what, when, where, and how. And then what are the beliefs, the thoughts, the emotions, the behaviors associated with that? What did you tell yourself? What were you thinking? What were you feeling? And then what were the consequences of that? What were the feelings and what were the behaviors? What happened? Making this a concrete sheet, giving this to patients where they can write on it and put this stuff down, bring it with them, can be so helpful. And then finally, shifting not just about our approaches, our professional selves, our skill sets with patients to match what we now know about addiction, but also our policy and our organizational changes. So thinking about our patients at our organizations, how long does it take for me to get into your treatment center for the care that I need? Does it take a couple of hours? Can it be that day? Does it take weeks? So assessing and really looking at our intake process. Is our biopsychosocial criteria too long? Do we have exclusionary criteria that really may be antiquated and no longer fits? And are we using strengths-based approaches to support client access? Are there exclusionary criteria that maybe don't fit into what we now know about substance use disorders? And then if I do get into your health center, keeping me in there, really exploring the spirit of policies. Even if our treatment has shifted, the spirit has shifted into a lot of the strengths-based approaches that we talked today. How about our discharge policies, or what happens to me if I miss appointments, or if I have positive urine screens, or I do return to use? Does that mean that I get discharged from the program, or does it mean that you say, gosh, we missed something, we need to provide Nick more resources, more support? And so those are some of the things that I think are really important for us to think about, to really shift and make that shift and change about how we address substance use disorders. So I know we're getting and I'm bleeding into a bit of our Q&A time, but I just wanted to mention some additional resources. August 14th, Robert Ashford, who is also a social worker, is going to be presenting on innovation and creation and recovery, the growing field of recovery science. I'm really excited to hear Robert's webinar on that, so please be sure to sign up for that on the IRETA website. Also, if you want more information from me or want to reach out to me or have any questions or comments, I always love to hear from folks of how to make these webinars better. You can reach out to me. My website is nsistrategies.com, and we'll be doing a webinar in September really focusing on a deep dive into the brief intervention component of SBIRT. I know IRETA's done some awesome work around SBIRT and helping all of us get that intervention set up in our treatment centers. But if you want to take a deep dive into SBIRT, please let me know. So I think, Jess, this kind of rounds us out, and maybe we can move into some Q&A.
All right, absolutely. Thank you so much for that presentation. And we've been getting some questions coming in over the course of it. And I'll also remind people that they can submit questions now. So you can use the chat feature or the Q&A feature, and I will see it and convey it to Nick, or he may see it himself. So I'll start with a question about the interventions that you're talking about here. Do you find that it applies just as well to behavioral addictions like pornography, gambling, etc.?
Yeah, it's a great question, Jess. And so one of the exciting things about our webinar today and many of the interventions that we talked about is that it's really focused on how to treat addiction. And so a lot of this is really transferable to many of the behavioral addictions and also substance use disorders. And so these do work well for things like gambling or other addictions around, sex addiction, helping our patients really create a structure in where they are aware of what's going on for them so that they can better make those healthy choices that their brain is compromising them from being able to make. And that's the real important shift I think, that helps us address why patients do what they do. It's really these advances in the neuroscience that helps us understand why folks don't make some of the changes that we suggest and they also agree with. It's why relapse prevention planning and using all these different skills together at one time are so critical to help our patients, really giving them a plan for success.
All right, terrific. And the question asker says thank you so much. And then there's a comment here that I wondered maybe it would help you, you could expound on it. But you mentioned that you do some role playing with clients because sometimes their triggers are even within their own families. And someone commented exactly that that's an issue they encounter when people's triggers are within their own families. And so I thought you might want to speak more to that. Do you have other thoughts for how to deal with that?
Yeah, thanks, Jess. It's such a great question. One of the things that I think around this issue is really challenging is we say, we'll stay away from those people. Well, that's not always realistic because sometimes those people are an important part of our support circle. And they may be our own family, or the choice isn't so easy of just disconnecting from people that may be using or may be triggering or activating around our own personal use. And so I think that one of the things that can be really helpful for patients, and again, this becomes very individualized, but one thing that I found very effective in working with patients who say have to go to a family event or a family party is to first think about if they can make a proactive phone call. So is there someone in the family or the specific person that we're talking about, before they get to the event, can they call that person and say, hey, look, I want to let you know, I'm going to be there Saturday night, but I'm not going to be drinking. And I know that's a big part of what we do, and I just want to let you know that, I'm not going to be drinking, and I would really like your help or your support in helping me not drink. Would you be willing to do that? So sometimes we can actually elicit the person who is a trigger in that way. The other thing to do is if that person, we don't have that, is to find a buddy, a support, someone in the family who's going to help out, who, again, proactively we can connect with and say, hey, I'm not going to be drinking Saturday. You know how it is with Uncle Joe. You know how he goes at me. You know how he always wants me to drink with him. I'm going to need some help. If it gets, can we create a code word that if I say this word, you get me out of there and we go take a walk? So there's ways that you can elicit and create support for yourself while you're at and in that environment. And then, sometimes the third is also setting a time limit where if the party is, from 5 o'clock till midnight, make a commitment that, okay, I'm going to go, but I'm only going to go from 7 to 8 or 7 to 8:30 or whatever is a smart goal for that patient that's reasonable, that they think they can manage, and then come up with exit strategies, helping them find, maybe even model and practice conversations of like, Uncle Joe, it's great to see you, but I'm going to leave the party now. I got to get to go see a friend, or I promised someone I'm going to help them do something else. Practicing exit strategies so that they are not faced with needing to come up with a reason to leave and not drink at the party in that high intensity situation. So breaking all these components down, I think, can be really helpful for our patients that have to go into the sometimes difficult environments.
Okay, great. Thank you. So one of the other questions that we have here is, do you find these approaches are effective for people with narcissistic personality disorders?
Wow, that's a great question. So working with patients with personality disorders is definitely a different skill set, and brings in, like any patients who have comorbidities, different and unique challenges. However, I do find that a lot of these skills work effective with patients with personality disorders, most so because they benefit so greatly from the structure. Creating a structure for someone can be so helpful, which helps them take the thinking out of things. So coming up with ways to handle certain situations that are non-reactive, helping them come up with the triggers that they may have around different emotional responses can be very helpful. And putting that structure into place can actually really be a comforting component as we treat our patients, not just with narcissistic personality disorders, with all personality disorders, also with other comorbidities.
Terrific. Here's another question about applying these approaches to certain populations. This person says that they're a public school nurse in a middle school and is curious if these approaches can be applied to 11 to 14-year-olds.
Yeah, this again, right? This stuff I think is pretty effective for that age range. Today's webinar is really more focused on adults. However, a lot of the skills that we talked about, I think, are so effective for adolescents. And I can't think of a population where it's more important to develop rapport and to develop relationship. And if you're a nurse at a school with adolescents, you know that telling kids what to do and approaching from a parental approach or an authoritative approach is not going to work. And it doesn't work for adults, especially doesn't work for adolescents. So the spirit of using things like motivational interviewing and using this strengths-based approach where really we're eliciting from the patient, from the client, from the adolescent, the strengths that are within themselves, helps align and build the autonomy from within that person and removes us from that relationship of telling to truly partnering with and eliciting what strengths that adolescent may already have. And then coming up with a structure for them, helping adolescents deal with uncomfortable social situations, to help them deal with peers, the influence of their peer relationships in the peer group. Very challenging, unique stuff for adolescents, but many of the tools that we talked about here today are so applicable.
Excellent. The next question is that you talked a little bit in passing about using alerts and reminders with your patients, and this person just wants to know if they can know a little bit more about how you use alerts and reminders with your patients.
Yeah, thanks for asking the question. So a great example is, most of our clients now have their smartphones, and so scheduling in certain reminders for patients so that they are reminded to do things like maybe diaphragmatic breathing or doing a body scan to check in with themselves on what they're experiencing and what they're feeling can be so helpful. The other thing that you can do, according to our kind of some of the areas around time, how time can be a real dangerous spot for folks. So paydays or Fridays at 5 o'clock or Tuesdays at 5 o'clock after work, before work, really understanding the individualized patterns of our patients of times when they preferred to use or wanted to use. We can use things like calendar invites, reminders beforehand to remind them of those pro-social, proactive, positive alternative behaviors to using so that they don't even get to the point of thinking about 5 o'clock, oh gosh, should I take my paycheck and cash it and go to the spot, or should I take my paycheck and deposit it and go home and go join some friends in the park for, whatever. So I think building that structure in are some of those ways that can be so effective to proactively head some of those things off. But it really means creating a safe space with your client, with your patient, to talk about their individualized patterns of use, what they liked about using, how it helped them, how it supported them, where it did those things. Getting into that stuff helps individualize and tailor the tools and the interventions that we use today specific for them.
Mm-hmm. Okay, awesome. Thank you. The next question is about whether you have suggestions as to how to integrate 12-step recovery principles with ACT, CBT, and the mindfulness-based approaches that you've been talking about here.
Yeah, I love that question, and I typically get it because in this presentation, I talk a lot about empowerment and realizing that we have control and helping our patients realize they have control. And sometimes I get questions, is that in contradiction with some of the philosophy of the 12-step community? And I don't think it is. I think it's in harmony with it. I alluded to a little earlier to hedge myself if this question came up that this connects in a lot of ways. Mindfulness connects to the serenity prayer of helping our patients discern between understanding what they can control and then also accepting and allowing what they can't. So a great example of that is accepting control, that the way that I think is something that I can control. And that's very empowering because that means I can impact how I feel. However, I have to surrender and let go that if I have a feeling, an emotional experience, I can't control it and change it by the way that I think. That's a different process. I have to surrender into that emotion, allow myself to experience that emotion, validate that emotion, and that is what allows us to hold an emotion. And by holding that emotion, that's truly what allows us to let go of an emotion, to externalize that emotion. I can't externalize and let go of an emotional experience until I hold it, till I have it, till I grab it. And so I think that very much is in harmony with a lot of the philosophy, the wonderful philosophy of the 12-step community and support. The other fantastic support from the 12-step community is the social support, the fact that people who have a substance use disorder can connect with people with lived experience that is just different and a unique conversation and relationship that some of us in the treatment field have, some of us don't, but it's a different relationship, and it's a support. The 12-step approach, AA, NA, is not treatment. It is support. And if the patient decides, if the client decides that that's something that they want to check out, then I think it's great to support that. The converse is true, though, too. Some of our patients are not comfortable in that community. Some of our patients are not comfortable with group meetings or the dynamics or the beliefs of the 12-step community. And so, too, we must adjust our treatment plans and our relapse prevention plans and our recovery plans around those patients to be individualized as well.
Awesome. The next question, this person says they're always looking for new resources and handouts, and that you talked about giving a worksheet to patients to help them prevent relapse. Do you have copies of those worksheets, or do you have other suggestions about worksheets that they could hand out to their clients? And maybe if you do have copies, you would be willing to share them, then we could distribute them to the participants after the webinar.
Yeah, Jess, I'm happy to do that. I don't know if folks are still able to see my slide deck. So I think this is what the question is asking about.
Yeah, I think so too.
So, please, these slides are going to be available to you. You can take the slides. I also have this in a format, Jess, so I'll send it to you and we can email it out to everybody. But the great thing about this is when you become familiar with it, you can scratch this on a piece of paper. Like, you don't need a fancy form unless you want that, and that's great. But you also can kind of build this into a person's phone, in their notes section of their phone, helping them list this. And so happy to share this tool with you, but also to remember, it doesn't always have to be fancy. Some of our clients like the structure. Other clients just want to write it down in their book or their notepad. And so I suggest that you can do it whatever way works best for you and your client.
Okay, fantastic. And then this is the last question that's been submitted. And this person says they're very curious about ACT and they didn't get much training on it. And so they're looking for suggestions for other resources or websites to go to.
I don't know any offhand, Jess, but I can send some over to you when we send out those resources and include those as well. Okay,
terrific. So unless any questions just pop onto my screen, actually, we have participants that are sending some of their ACT their ACT resources via chat.
Awesome.
So I'll share those.
Awesome, that's great.
So we've got one person saying that ACT Mindfully is great with Dr. Russ Harris.
Cool.
And someone else saying Praxis, Praxis, has great ACT trainings.
Awesome.
So that's really cool that there's a community here that can give each other tips. All right. So
Jess,
thank
we really
you so
have
much.
Someone from Australia, it looks like. That's so cool.
Yeah, holy smokes. Yeah, it's like 6 a.m. there.
Well, thank you for attending in Australia. That's awesome.
Absolutely. So I guess that we will sort of close the Q&A portion, and I wanted to thank all of you for attending and for your great questions, and of course thank you, Nick, for such a great webinar and for answering these questions as they've come up. If you don't mind, I'm actually going to take the presenter role back so I can demonstrate to people how to get their CEUs and certificates.
Jess, I just wanted to say thank you so much to you and Irita for having me. It's just such an honor and a privilege to talk about this stuff, and also thank you to all of you out in the audience doing this amazing work. It is hard work, it's challenging work, and you're really bringing a lot of help and healing into your communities. And so it's an honor and a privilege for me to be here. And again, I just want to offer, if anyone has any questions or comments or thoughts too on how to make this webinar better, or what ways we could provide information in a way that's going to more help you do the work that you're doing, I'm all ears about that. And so you have my email and contact information. Please don't hesitate to use it. You can even call my cell phone. I always offer that because no one calls it.
Well, terrific. Yeah, I reiterate thanks to you,
Okay.
and we're getting lots and lots of chats saying thanks to you as well.
Okay, great.
And then this is sort of more housekeeping stuff. So for those of you that want a certificate or CEUs, you might want to stay tuned. At this time, I'll go over our evaluation and CEUs. We're going to send you a couple emails after this webinar. The first will include a link to the evaluation, and it will have information in it about how to access your certificate of attendance and CEU certificates. You'll also receive a more detailed email after that email with step-by-step instructions on how to access your certificates. However, here we are now, so here's some information about accessing your certificate. You'll want to log into your MyIRETA account and scroll to the bottom of the page where it says CEUs and Certificates of Completion and click on your choice of whichever type of CEU you're interested in, and then click Download Certificate. As Nick mentioned, we have several webinars coming up, and the closest upcoming one is in August, and it's Robert Ashford presenting on the new developments in the field of recovery science. So we're really excited about that, and we encourage you to sign up. We also really would like to encourage you to fill out the evaluation. It literally only takes 2 minutes of your time, and it really helps us make these trainings better. So we'll send you, we've also, of course, gotten questions about this. For those of you that love these slides and want to review them more closely, we'll send you a PDF version of the slides early next week, and we'll also send you the recorded webinar to view on your own time more closely as well. If you want to make sure that you stay in touch with us for further updates, you can sign up for our newsletters and follow us on social media. And if you have any specific questions about this webinar or anything else, you can send us an email at info@ireta.org. Finally, I just want to thank you one more time for your participation today, and we hope you have a great afternoon.
Thanks everyone.